A warm good evening, everyone. It's a great Sunday today. It's the fourth day of the International E-Conclave. Very interesting day because on the last 4 days we have been, since the last 3 days we have been speaking about a lot of things about pharmacotherapy related to tobacco cessation. So today we have the consensus whereby all the moderators from the last three sessions are going to present a short summary, and then we are going to have a great panel discussion with the topmost surgeons from different specialties across the country. I'll now invite Nandita ma'am, Dr. Nandita Diwekar. She's consultant in anesthesia and critical care at Medway NHS Trust in UK. She had been leading a smoking cessation program in her hospital and is very passionate about the cause. She had been the moderator, the COE opinion leader for the first day. So I'll invite ma'am to kindly summarize the event for the day.
Thank you, Shruti. Namaste, greetings, and good morning on a fantastic day from UK. And thank you to ICanCaRe, Dr. Pawan Gupta, Dr. Reena, Dr. Desai, Shruti, Rishabh, and everybody else for giving me this wonderful opportunity again. So we started on the 4th of July, 4 Sundays, it's the fourth Sunday now, and with a grand opening ceremonies. Dr. Swasticharan, thank you very much for your opening address, and your support is very well appreciated by all. We had addresses from Dr. Gupta, Dr. Desai, and Dr. Reena Kumar, and other dignitaries as well. And then we started our session. The first session was by Dr. PRABHAT, who was a speaker on pharmacological modality for smoking cessation, counseling versus medication, and it was chaired by Dr. Kolhatkar. He suggested the importance of affirmation, resilience, and empathy. Remember not to ridicule the person. That's really bad. And it was an exciting interactive session with lots of questions and answers. He told us how to elicit what has helped in the past. We are facilitators and we provide support. We are the anchors sometimes for them. We can provide booklets for quitting, advise patients about why is it important to say no when you're amongst friends or relatives to smoking. Fix a quit date, try and stick to it. What happens if we cannot stick to the quit date? And what are the high-risk situations for relapse, like being in isolation, alcohol, or going on a long drive, etc., etc. And Dr. Kolhatkar then said that these suggestions can be extrapolated to children, and we are the facilitators of change. Next slide, please. And then Dr. DEEPAK Kumar, he spoke about mostly bupropion, integrating pharmacotherapy for smoking cessation. And we know that tobacco causes premature deaths. One can make a lot of difference with minimal intervention. It takes only 30 seconds to make a difference in the life. Pharmacotherapy can cause a 36% reduction in mortality, and health benefits start as early as possible. Again, we all know, and it's important, that combination of counseling and medication is more cost effective, and telephone quit lines are also very effective. Dr. Pankaj Kumar concluded that quitters are winners. Without support, it can be very challenging, and there is a big gap in accessing smoking cessation services. Some other points which Dr. Kumar said was we should involve family and friends. And apart from NRT, we have varenicline, bupropion, nortriptyline, clonidine, selagelin, and some other medications as well. Next. So bupropion was invented more than 18 years ago. It's the first non-nicotinic based antidepressant with dopaminergic antagonistic action. It is an antagonist at the acetylcholine receptor, as we know. It targets craving, and a Cochrane review shows edge over placebo. If there is no response by 7 weeks, remember, it may not be as effective. It can cause headache, dizziness, insomnia, but less weight gain. And it is contraindicated in epilepsy and alcohol disorders. It was one of the drugs studied in Eagle's trial. And then we went to Dr. Malay Dave's session on varenicline. It is a bespoke drug for smoking cessation from 1997. Mainly works at the alpha-4 beta-2 receptors. Sorry, there's a mistake there. Nicotinic acetylcholine receptors. It inhibits nicotine-induced dopamine release, reduces craving and pleasurable effects of cigarettes. It has got high bioavailability, slower elimination, and there is no liver involvement. It has also been studied in many RCTs. Eagle studied removed the black label by FDA, and 50% of the patients maintained abstinence at 12 weeks. He then said that the degree of dependence predicts abstinence. At present, it is withdrawn due to some concern that it contains nitrosamines, which could be carcinogenic. So we await the results of further studies. And it can be used in smokeless tobacco as well. Next slide, please. So we then went on to a very interesting case discussion, which was actually presented by myself, and I had an excellent panel of Dr. Gupta is a cardiologist, Dr. Sandhu, who's an oral max fac surgeon, Dr. Munde is a pulmonologist, Dr. Jain, who's a thoracic oncologist, and Dr. Kulkarni, who's a psychiatrist. And we discussed a case of a male with an out-of-hospital VF cardiac arrest, who luckily survived. He had non-ST elevation MI, and he was a very, very heavy smoker since the age of 15. So we discussed that very brief advice should be done as soon as possible, and it has got a very promising effect. Ask, advise, assist, or act, and nudge the patient to stop. The cardiologist advised us we should talk about cardiac illness and talk as soon as possible about the VPA, but also look for other symptoms of respiratory, GI disease, etc. And the impression from the cardiologist further was that the person with authority, like a doctor, mentions the importance of quitting, and 30 to 40% of the patients then quit. And chances of cardiac problems going to normal within 4 years are very high, and that should be mentioned to the patient. Next slide. Don't delay treatment. Very important, because if a patient can quit, the second event can be prevented. It is a teachable moment, Dr. Sandhu said. We can give combination therapy as well. We have to look out for side effects like GI symptoms, abnormal dreams, insomnia, tachycardia, but reassure the patient that it will take effect. It takes time. And most important point they suggested was a multidisciplinary team is needed, which is absent at present in many hospitals. It needs an effort from the treating physician. All patients who are inpatients or outpatients should be screened whether they are smokers or not, and it should be noted somewhere. And in event of adverse events, don't blame the drug only, because treatment may need to be continued. You need to find out the cause. The primary event may be the cause, say maybe blocking of stent or another MI. And discharge follow-up is very important. Do we have a system for that? Should we build up a system for it? And last, we discussed about the effects of COVID on smoking cessation. We know that WHO has described tobacco as the only legal drug that kills many of its users when used exactly as intended by manufacturers. And smoking is associated with increased severity of disease and death in hospitalized COVID-19 patients. Yes, COVID has prompted many patients to quit, but at the same time, because of isolation, because of worries, because of job losses, many people have taken up smoking. So do we as a group join hands together and think that it is our responsibility to help our patients to quit, or at least assist them towards quitting? Thank you very much.
Thank you so much, ma'am. So we had the first summary from our key opinion leader from day one. That was a summary about varenicline and bupropion altogether. So